Hi, I'm James Park, a surgical oncologist and physician scientist at the University of Washington Medical Center, Seattle Cancer Care Alliance. As a surgeon who treats cancers involving the liver and pancreas, I rely heavily on CT, computed tomography scans, and MRI, magnetic resonance imaging, to help determine the best treatment for each patient. As advanced as these scans have become, however, they are not as accurate as patients and clinicians need them to be. Our research aims to improve our ability to detect and stage cancer using an innovative imaging approach. While our focus is on liver cancer, this technology can be applied to all solid cancers and will likely be the way that we view all cancers in the not-so-distant future. First, a little bit about primary liver cancer, also known as hepatocellular carcinoma. Most people are unaware that liver cancer is the second most lethal malignancy worldwide, responsible for the deaths of 750,000 patients every year. That's right, 750,000 people, number 2 in the world. In the US, the rate of liver cancer has been steadily climbing over the past 3 decades, while cancer in general has been on the decline. Liver cancer already ranks 5th and 9th in cancer-related deaths. However, with the obesity epidemic currently plaguing our society, which predisposes millions of Americans to fatty liver disease and liver cancer, these figures are only expected to worsen. So how is liver cancer diagnosed on CT or MR imaging? The contrast infused into a patient undergoing a CT or MR scan is processed by the normal liver and cancer tissues differently. Recognition of this characteristic enhancement pattern at specific times following contrast administration is how radiologists make the diagnosis. While CT or MRI can diagnose liver cancer, accuracy of these scans is inherently limited by their poor sensitivity and lack of specificity. The smallest cancer that a perfectly performed CT or MR scan can detect is the size of a pea or peanut, consisting of billions of cancer cells. And because these scans rely on contrast timing, they cannot guarantee that what is being visualized is in fact cancer. Inaccurate scans not only result in costly re-imaging with additional radiation exposure to the patient, but also potentially harmful and unnecessary biopsies. Patients undergoing surgery for liver cancer have recurrences due to small tumors that were not visible prior to surgery, as demonstrated in this case. On the preoperative scan, the tumor is visualized as a solitary mass. However, only 6 months following operation, several tumors have grown in the regenerated liver. If these tumors had been detected prior to surgery, either an unnecessary operation could have been avoided, or other treatments could have been employed prior to surgery. Eligibility for liver transplant is based on the number and size of tumors. You can imagine how inaccurate scans can adversely affect patient outcomes and organ allocation. Dr. Minashima and I set out to create a new type of scan that can detect smaller liver cancers with greater accuracy than current CT or MR technology. Together, we developed an antibody against a marker expressed on the cell surface of most liver cancer. This antibody was then labeled with a radioisotope called zirconium-89, which can be detected on PET, positron emission tomography scan. Mice with liver cancers that express this marker were imaged using this antibody radioisotope conjugate, and we were able to accurately detect minute tumors, smaller than the size of a pencil tip. Next step is to bring this technology to the clinics to help our patients with liver cancer. But first, we need your help. Please support our research efforts through Consano. Thanks very much for watching our video.